Bismillahirrahmanirrahim. In our previous lectures, we studied cellular adaptations to stress, reversible cell injury, and after passing through the stage of reversible cell injury, if the injurious stimulus is strong and if it is inherited, the cell will go into the stage of irreversible cell injury and the cell will die. Cell death pathologically is discussed under two headings: necrotic cell death and another form of cell death known as the apoptic cell death or apoptosis, which is a type of suicide that the cell performs. Necrotic cell death is the most common type of death that causes death of the cell and tissues in most instances, and we have discussed that in the reversible cell injury, if the cause is removed, the cell has a chance to reverse back to its normal physiological and anatomical state. But there are certain changes which make it irreversible for the cell to return to normal, and this cell will undergo death. In necrosis, the two main things that occur is the loss of integrity of the plasma membrane of the cell and the damage to the nucleus. So, necrotic cell death is the death associated with loss of membrane integrity, followed by cellular dissolution by the lysosomal enzymes. Now, these hydrolytic enzymes are either contained in the lysosomes of the damaged cells, and they are also derived from the leukocytes, which are recruited to the site of the damage as a result of inflammation. Characteristics of the necrotic cell death include amorphous densities in the mitochondria and the presence of myelin figures, which are whorled masses of phospholipids along with calcium. In necrotic cell death, there is breakdown of the plasma membrane and the membranes of the organelles, and there is damage to the nucleus, irreversible damage, and mostly in necrosis there is an element of inflammation because the necrotic cell death or the injury, it will cause infiltration and recruitment of the inflammatory cells, initially in the form of the neutrophils and then in the form of macrophages and lymphocytes. The morphological changes of necrotic cell death are described changes in the cytoplasm and changes in the nucleus. In the cytoplasm, we can see increased eosinophils because during tissue processing, when we treat the tissue with hematoxylin and eosine stain, what happens that normally the eosine colors the cytoplasmic proteins and the hematoxylin, it will stain the nucleus and it will appear blue, while the cytoplasm will appear pink. So what happens in necrotic cell death, that the cytoplasmic proteins are denatured and the eosine stain and the He stain binds to these denatured cytoplasmic proteins, which gives a comparatively bright pink appearance. Normally in the ribonucleic acid, it gives the blue coloration, but in necrotic cell death, the enzymes that degrade the RNA will result in the decreased or fade blue appearance of the cytoplasm. So as a result, the cytoplasm will appear a homogeneous glassy mass, and mostly the cytoplasm is vacuolated and appears like mouth eaten. The myelin figures are derived from the membranes of the organelles and plasma membrane, and these are actually the walled masses of the membrane contained phospholipids along with calcium. Now coming to the changes in the nucleus, the three types of the changes that occur in the nucleus are the karyolysis, pyknosis, and karyorexis. In this slide, we can see a normal cell here, and the cell nucleus will undergo either karyolysis, it will undergo pyknosis and karyorexis. In karyolysis, what happens that normally the blue stain, which is imparted by the hematoxylin in the H stain, it becomes fade because the activated DNases, deoxyribonucleases enzymes, they cause degradation of the DNA, and the blue color comparatively fades. The second change, known as the pyknosis, it occurs because the nucleus undergoes shrinkage, and as a result of condensed mass of the DNA, it may appear more blue as compared to normal cells. Now what happens that these pyknotic cells, they will get break down into fragments, and this type of pyknotic nucleus fragmentation is known as the karyorexis. Now some types of the tissue necrotic cell death gives a particular gross and microscopic appearance, and that may help us to in the diagnosis of the underlying disease. So most types of the necrosis, they have distinct gross appearance, and they will indicate us as a clue to a particular disease, even with the naked eye appearance, by what we mean the gross appearance. However, one type of tissue necrosis, which is an immunologically mediated inflammation of the blood vessel walls and known as the fibrinoid necrosis, that may not give the gross appearance as apparent as to indicate the underlying disease, and for this we will use the microscope, and only after histological examination or histopathological examination we will be able to label it as the fibrinoid necrosis. There are 6 patterns of the tissue necrosis: coagulative necrosis, liquefactive necrosis, gangrenous necrosis, caseous necrosis, fat necrosis, and fibrinoid necrosis. We discuss briefly about all of these patterns. Coagulative necrosis is most common in solid organs, and it is usually the result of loss of blood supply. And whenever a tissue or a part of a tissue is deprived of its blood supply, it will undergo ischemic necrosis, and that is known as the infarcts. But one characteristic of the coagulative necrosis is that there is no total dissolution of the tissue, and the cell outlines are maintained. The reason behind is that the injury causes uh, denaturation of the structural proteins, and as well as inactivation of those enzymes that will cause proteolysis. So inactivation of the proteolytic enzymes result in blockage of the proteolytic breakdown of the cell, and as a result the cell or the tissue integrity is maintained at least for a few days. We can see that the component cells are dead, but we can identify the basic tissue architecture. This type of necrosis, in which the cellular outlines can be identified for at least a few days, most commonly occurs in solid organs, for example, the heart, kidney, and spleen. However, this integrity of the tissue is short-lived, and ultimately the injury will lead to inflammation, and the leukocytes are recruited to the site of tissue death, and the dead cells present there, they are digested by the lysosomal enzymes of the recruited leukocytes, and will be these dead cells will be removed by the phagocytosis of the cellular debris that is performed by the leukocytes. In this picture, we can see a kidney in which there is a wedge-shaped kidney infarct, and here the outlines of the cells and the tissue are preserved. Under the microscope, this is the normal kidney tubules, while this area represents the coagulative necrosis, and here we can see that the cells are dead, anucleated. There is no nuclei in the cells. However, the cell walls or the borders are maintained and can be identified. So in this type of necrosis, there is the integrity and of the tissue is maintained at least for a few days, and the tissue is firm and can be identified under the microscope as well as on gross appearance. The second type of necrosis is the liquefactive necrosis. By liquefactive means that the necrotic tissue is transformed into a liquid mass. The liquefactive necrosis is most commonly seen in focal bacterial and rarely fungal infections. And what happens in liquefactive necrosis that the structural proteins are denatured, as well as there is infiltration of the leukocytes, and the lysosomal enzymes derived from the dead cells as well as from the recruited leukocytes, they will cause digestion and liquefaction of the tissue, and will result in the formation of a liquid viscous mass. If this injury is initiated by a bacterial infection, and if it starts as an acute infection, the dissolution of the dead tissue will result in the formation of pus, particularly in bacterial infections and containing lot of polymarbonuclear leukocytes. Here one thing important that I want to mention, that unlike other tissues of the body, the central nervous system and the brain particularly, they do not undergo coagulative necrosis. And in the central nervous system, there will be always liquefactive necrosis. We know that hypoxic or ischemic injury to a tissue may result in coagulative necrosis. But the exception is the central nervous system, the brain, where ischemic or hypoxic injury will always result in liquefactive necrosis, and there will be no coagulative necrosis. Now, another type of tissue necrosis is the gangrenous necrosis. Usually, the gangrenous necrosis are a gangrene. It is most commonly seen, particularly in the lower limbs, and commonly in diabetic patients also. But the mechanism of gangrenous necrosis starts initially with the loss of blood supply. There is ischemic or hypoxic injury, and at this time, what happens that here coagulative necrosis occurs. In the stage of coagulative necrosis, the tissue and the cellular outlines can be identified. And in this stage, we say it is dry gangrene. Later on, when this area becomes infected by bacteria, which is the superimposed bacterial infection, what will happen that the infiltrated leukocytes, they will release lysosomal enzymes and will cause dissolution and liquefaction of the necrotic tissue. And at this stage, we call it as the wet gangrene. So, gangrenous necrosis itself is not a specific pattern, but it is a combination of the coagulative necrosis as well as the liquefactive necrosis. Caseation necrosis is another type, and it is particularly seen most commonly in tuberculous infections. And what happens that in tuberculosis, the type 4 hypersensitivity reaction or T cell mediated hypersensitivity reaction occurs, and the recruited macrophages, they undergo a change into a specialized type of cells known as the epithelioid cells. Now what happens that the epithelioid cells, they will undergo necrotic cell death, and we will get the very specific appearance of tuberculous granuloma, which we can define as the localized collection of modified macrophages known as the epithelioid cells. And this localized collection of epithelioid cell is surrounded by lymphocytes, and outside the lymphocytes there is an enclosing rim of the fibroblasts. So what happens that necrosis and dissolution of the epithelioid cells will result in the formation of caseation necrosis, and in caseation necrosis the cellular outlines cannot be identified, and the tissue or the lesion appears in the form of friable yellow-white mass surrounded by an inflammatory zone, and usually it has a cheesy white soft appearance. And mostly when we excise a lymph node in making the diagnosis of an infection where the disease is spread to the lymph nodes, so when we open the lymph node, it has a very specific friable cheesy soft appearance which is white in color, and we can easily say before the histological examination that this is caseation necrosis, and we know that caseation necrosis, the most commonly it is caused by the tuberculosis. Fat necrosis is a condition in which there is death of the fat cells. Commonly, fat necrosis is seen in conditions of acute inflammation of the pancreatic tissue. We know that the pancreas contains enzymes that help in digestion, for example, pancreatic lipases, amylases, and proteases. So, what happens that when the pancreatic tissue is injured, there are there is the release of pancreatic lipases. And normally, lipases are the enzymes that will break down fats. So, what happens that in acute pancreatitis, the injury to the pancreas will cause death of the pancreatic cells, acinar cells, and there will be the release of the enzymes known as the pancreatic lipases. Now, what happens here that as we know that lipases are the enzymes that will break down fats. The lipases, they will break down triglycerides present in the fat cells located in the peritoneum, and what will happen that breaking down these triglycerides by the pancreatic lipases will result in the release of fatty acids and glycerol. And these fatty acids, they will combine with the calcium, and this process is known as the saponification, and it will result in the formation of the fat soaps. So fat necrosis is particularly seen in conditions where there is injury to the pancreas. In this picture we can see the fat necrosis in acute pancreatitis, and they represent it as areas of white chalky deposits, which indicates foci of fat necrosis, and the addition of calcium or saponification will result in the formation of calcium soaps. Under the microscope, when we treat the tissue during the tissue processing, what happens that passing through the a stage in which the tissue in the tissue processing is treated with xylol, it will dissolve the fat contained in these cells, and these cells will appear as the empty cells or under the microscope, because the fat contained in these cells, it will be dissolved by the xylol when we treat the tissue with xylol during the process of tissue processing. Fibrinoid necrosis is a very peculiar type of necrosis, and in this type of necrosis we have to make the diagnosis after histopathological microscopic examination of the tissue, because on gross appearance we can't make any diagnosis, and this is the as compared to other patterns of necrosis, the fibrinoid necrosis can be diagnosed only under microscopic histopathological examinations. This type of necrosis is mostly seen in the disease polyarthritis nodosa, in which there is vasculitis or inflammation of the blood vessels. And as we know that the polyarthritis nodosa is a disease which is immunologically mediated, which is an immune disorder, and in which what happens that the antigen, and as a result the forming antibodies, these antigen antibody complexes, also known as the immune complexes, they are deposited in the blood vessel walls. Now when these immune complexes combine with the fibrin, this whole structure will give the appearance, fibrin-like appearance, which is known as the fibrinoid necrosis, and usually they appear as bright pink amorphous when we treat the tissue with the hematoxylin and eucin stain during the tissue processing. So coming to a summary of the today lecture, reversible injury we have discussed in the previous lecture, and in reversible injury the two common changes are the cell swelling and fatty degeneration, the blibbing of the plasma membranes, and the loss of microvilli, swelling of the mitochondria, endoplasmic reticulum, and as a result of decreased cytoplasmic RNA, there is eosinophilic. because this is the RNA which gives the blue appearance under the H stain, but when the RNA is decreased, the cytoplasm will appear more pink and eosinophilic. In necrosis, we can see increased eosinophilia, nuclear shrinkage, and fragmentation of the pyknotic nucleus known as the karyorrhexis, its dissolution, and there is breakdown of the plasma membranes and also membranes of the organelles, and there is the formation of myelin figures, which, as we discussed, are the whorled masses of phospholipids along with calcium. And in necrosis, which is the major difference between necrosis and apoptosis, is that in necrosis there is leakage of the lysosomal enzymes into the outside, which will stimulate an element of inflammatory reaction. In the pattern of tissue necrosis, we discussed coagulative necrosis, which usually occurs as a result of ischemic and hypoxic injury, and liquefactive necrosis, which will occur when there is superadded bacterial infection. And one thing important, that in the central nervous system there is only liquefactive necrosis that occurs, and there is no coagulative necrosis. In gangrenous necrosis, we discussed that it is a combination of the coagulative necrosis and at that time it is called dry gangrene, and when there is superimposed bacterial infection, there is a type of liquefactive necrosis, and now it is known as the wet gangrene. Caseation necrosis is typical of the tuberculous infection, and in fat necrosis there is release of pancreatic lipases that will cause digestion and degradation of the fat cells in the peritoneum. And the fibrinoid necrosis, which is particularly a type of necrosis that can be seen only under the microscope and cannot be identified on its gross or naked eye appearance, is the result of immunologically mediated diseases like polyarthritis nodosa, in which the antigen antibody complexes or immune complexes bind to the fibrin and gives us a fibrinoid appearance. Thank you very much.